Doctor, we have a number of submitted questions. They're done without names. Some are, some aren't. First one, if IGG and M-spike are stable, but Kappa-free light chains are going up, does this mean cancer is progressing?
If Kappa line chain is increasing, the cancer is progressing. Of course, it depends on the magnitude of increase. So, if it is an important increase, yes.
And what would an important increase be?
An important increase should be at least more than 30, 40, 50.
Okay. Ariana writes, what is the view of using Velcade prophylactically after a stem cell transplant? Her husband, now 54 but 51 at diagnosis, had autologous stem cell transplant in 2013, which was left him with 5 to 7% myeloma on biopsy post-transplant. As this is only a partial response, his consultant suggested Velcade prophylactically to increase time before relapse, and he began this in September 2013, but has made it clear that she does not know the efficacy rates.
Well, this is a very similar question to the previous one. Of course, you can have a continuous treatment with lenalidomide or with Velcade. They are basically similar from that point of view. One is injection, the other is oral, but basically both are effective. The issue is the moment you have a residual tumor, if there is no toxicity, is wise to use a continuous treatment to keep the tumor under control. Otherwise, if you stop, the probability of relapse will increase.
Okay. Would you suggest adding like Velcade Dex to that, or thalidomide Dex?
Well, this is honestly, we do not have evidence for this.
Right.
That Dex, I would probably start in our practice with a single agent, eventually add a second agent if I'm starting to see that something is moving. Otherwise, if everything is absolutely stable, I will keep one agent approach.
Is that a cost consideration, or is that a...
No, of course, to add dexamethasone is not adding any cost. So,
right.
So it's not, no, I would use a single agent. Today we do not have evidence that two agents are better than one as continuous therapy. So.
Okay. How long should a myeloma patient continue a treatment such as Revlimid or Velcade? You talked a little bit about that.
That was exactly the question of before. More than how long, I would stress the concept, continue if no toxicity are coming.
Okay.
Because with toxicity, stop it. We do not have any data to say that 2 years versus until progression there is a plus of one approach versus the other. There is a US studies ongoing. They will probably give us this answer, but today we do not have any data.
And then the next question is, when you are dealing with patients that have multiple prognostic indicators for high-risk disease, in particular 17p, 1q21, and FISH13 deletion, how do you determine the most appropriate treatment regimen?
My answer is unfortunately coming from a Barlogi answer. I do not have any. Today we do not have any specific treatment for high-risk myeloma. We of course, do use a dose-intense treatment for these patients, but certainly today there is no specific treatment for high-risk patients. So we certainly use, I would say, in an autologous transplantation, I would use bortezomib induction, autologous transplantation, lenalidomide maintenance in a younger patient, and I would use once again a bortezomib-based induction, eventually followed by lenalidomide or bortezomib maintenance in a non-transplant eligible patient.
Okay, which answers the next one, what is the role of transplant? Single, two, or more for high-risk patients. So you just talked about it.
We use, of course, for high risk, two transplant are indicated because, of course, we are certainly giving, for the high risk, we give our best treatment. But we should give basically the same for the standard risk because the standard risk will do much better than high risk. So today, the answer is deliver a dose-intense treatment and no specific or peculiar regimen is indicated.
Okay, but you would use a tandem?
Yeah, tandem for high risk.
Okay. Do you use a lot of tandems then?
We use a tandem in all patients.
In all patients?
Yeah.
Oh, okay. So do you also use VDT pace as well as melphalan during that? No?
No.
Okay. All right. They do that in Arkansas, correct?
Yeah. No. We use VTD because it's reimbursed. VRD is not reimbursed, so we use VTD induction, double transplant, and VTD consolidation. Okay,
so PACE would not have been reimbursed.
Yeah, it's of course a reimbursement issue, at least in my country. Well, all over Europe, the VRD is not reimbursed, so it cannot be used.
All right. Does okay, and we talk. Okay, and the next one is really the same, but with a few other things in it. 414 is does autologous stem cell transplantation have better outcomes for certain aberrations like T414, deletion of 17, T14, 16, etc.?
No. The things are much easier. First of all, do not pay too much attention to prognostic factor. On a single patient, the prognostic factor are not so predictive because we do not have biomarker that gives me a 95% probability to predict a given outcome. The prediction is around 35%. So we have one option out of two that is absolutely low as specificity in terms of predictors. Generally speaking, the conclusion is, of course, that high risk do worse than standard risk, but on a single patient, still everything can happen.
Okay. What would your treatment strategy be for a high-risk patient whose induction with RVD responded well, as it typically does, but relapse was quick? Treatment with CCD are not working, meaning poor or non-responsive enough.
No, you see, for this type of patient, first of all, do a nice induction. And for them, certainly VRD induction, double transplant, VRD consolidation. Probably in this patient, the maintenance should be a VRD cycle every 2 to 3 months to keep the tumor under control with a dose-intense continuous therapy. So this should be done certainly in terms of induction to give the maximum and prolong the remission duration as long as possible. After relapse, certainly, once again, the two options are kyprolis plus len or cyclophosphamide.
Okay. One thing we learned, or not learned, but one of the things that Dr. Loniel from Emory mentioned, he had some pretty good results with a single transplant, but with high-risk disease, and I can't remember the induction, but he's
using exactly the approach I just mentioned before: VRD transplant, VRD, and keep going with the same schema. I have to make today. Honestly, we use that tandem. There is no evidence that tandem is superior to single. There are ongoing studies that are evaluating this issue, but honestly, I cannot say that 2 is better than 1. Today, no one can say 2 is better than 1 or 1 is better than 2.
Okay, and his research would indicate that,
he
was thinking, and it's not research, he just says it's supposition on his part, and the supposition was that the genetics of the high-risk patient is unstable, and melphalan can aggravate that, and so if you had higher doses of melphalan, which is a second transplant, that could be more negative than positive. But
the difference between Europe and U.S. We rely much more on evidence coming from study than on personal opinion. Generally speaking, the evidence today is that if you give autologous transplantation in high-risk patients is better than if you don't give it.
And that's based on clinical trials?
We do have this evidence from trials.
Okay, and I know you've got a tremendous amount of experience with clinical trials. You've tried about everything in Italy.
More or less.
Yeah. Does a European perspective of myeloma treatment emphasize more of the cure of myeloma using intense multi-drug strategy aimed at complete response, or more on the control of myeloma aimed at quality of life?
The cure rate today, let's say, can be stand between 15 and 25%. So we stand more for control.
Okay. All right. In early therapy in the newly diagnosed multiple myeloma and in smoldering multiple myeloma patients, is it more advantageous or disadvantageous according to you? Early
is always more advantageous.
More advantageous. Okay. And could you give your opinion, and you already have a little bit, on monoclonal antibodies in treatment? And I would say, is that would it be a signal agent? It would be in combination.
Oh, it would be a combination.
Part of the
would be a combination with
transplant.
We will basically add the monoclonal to current treatment schema.
You would add it to carfilzomib?
Yeah. The future will be that basically we will add monoclonals to what we are using today. So RD, VD, VRD, CRD, and so on.
Okay. Fantastic. Priya, anybody on the line?
Okay.
Okay, one other thing. Any last questions for Dr. Palumbo from the panel?
Hi, Gary. Can you hear me?
Yeah.
Hi. Okay, I do have a follow-up. So, Dr. Palumbo, from the perspective of a patient who's on long-term therapy or maintenance therapy, for example, what are the risks of becoming immune to those drugs so that they no longer work? So, is perhaps a better option to maybe go, if a patient is in remission, to go off of the treatment so that when a patient relapses, those drugs are still effective?
No, the balance is if you do not do anything, the risk of relapse is 70%. I'm giving just number to give you ideas. If you give a continuous treatment, the risk of more aggressive disease is 20%. So it's always true that giving a continuous treatment, you are going to chemoresistance, but it's much more prominent the risk of not doing anything and do have an aggressive, I'm not saying a relapse. So the balance is between continuous therapy that keep the tumors under control and avoid the creation of new genetic mutation that might increase the aggressiveness of the tumor, and this is much more prominent in comparison to the risk of having anyway a genetic mutation that will make a tumor more aggressive.
Okay, that is a very good reason to stay on maintenance therapy. Thank you.
And thank you for joining us, Lizzie.
My pleasure.
You just jumped right in there like you're a pro.
Unfortunately.
And Dr. Palumbo, as I stated before, I put a list together who I thought were the great 8 of myeloma specialists in the world, and you're on my list, and also very highly rated by Pat, who is very, very much a part of the patient advocate population. So we just thank you so much for the time that you've spent with us, and for your insights and the differences, and obviously you guys in Europe do more with less, and you do more with less because you have less than half of the cost per patient, and you do more because you don't get the drugs as quickly as we do. So the fact that your average life expectancy is as good or better than that in the United States speaks volumes for your efforts. So thank you so much.
Well, thank you for everything. Thank you for the invitation. Thank you very much.
Thank you. Thank you, Gary. Dr. Palumbo, it has been great listening to you. Lucy, Pat, and Jack, thanks a lot. Please join us again for our next myeloma episode, when we'll be discussing early treatment of myeloma with Dr. Irene Gabriel on Feb 16th at 6 p.m. Eastern Time. The link for today's broadcast will be shared with all participants. Please visit curetalks.com to register for our shows. Until then, thank you.
Thanks again, Doctor.